our next speaker, Dr. Shraddha Joshi. She is from Pune only. I think there are so many faculties today from Pune. I welcome them. She works as a consultant neonatologist at Dinanath Mangeshkar Hospital and Research Center. She is a faculty of National Nutrition Workshop, DNB Pediatrics from Dinanath Hospital. She has worked for 2 years at Vivekananda Medical Institute, Palampur, as consultant pediatrician. She has presented so many posters, cases at so many conferences. She has done, she is doing at present a trainer course for NRP. So here I present Dr. Shraddha.
Thank you, ma'am, for the kind introduction. So today we are going to be talking about neonatal screening. When we talk about neonatal screening, what is our goal? Now, our aim and goal is to detect disorders which can be threatening to life or which can affect the long-term health of a baby. We aim to pick up these disorders before the child becomes symptomatic. We all know that early treatment can reduce morbidity and mortality. Now, neonatal screening, newborn screening, there is a long list of conditions for which every newborn can be screened. We all know we can screen them for inborn errors of metabolism, endocrine disorders, hemoglobinopathies. The list is very long. In the next 3 lectures by me, Dr. Sagarlal, Dr. Preetilal, we will try to put forward evidence for the basic minimum conditions for which we strongly feel that every newborn should undergo screening. So in my talk, I will basically be covering all the blood components that every newborn should be screened for, as well as hearing screening. The rest will be covered by Dr. Sagarlal and Dr. Preetilal. Now, when we go back to history, newborn screening was started way back in 1960 by Robert Guthrie. The test was done for PKU, and the name was bacterial inhibition assay. Since then, there are several advances in technology that have taken place. We have various tests which are used for newborn screening. TMS is very famous. With the availability of TMS now, mass screening can be done for several conditions by using a single dried blood sample. Second is RIA and isoelectric focusing. So there are a lot of technology advances which have taken place now, which makes things easier for us. Whenever we recommend any condition for screening, any disease for screening, we should ensure that certain criteria are fulfilled. These are quite famous. This is called as Wilson and Jugner criteria for disease screening. So any condition we recommend for screening, we should ensure that these criteria are fulfilled. First of all, the condition should be an important health problem. Secondly, there should be an acceptable treatment for patients with recognized disease. Facilities for diagnosis and treatment should be available. There should be a recognizable latent or early symptomatic stage. There should be a suitable test or examination. The test should be acceptable to the population. The natural history of the condition, including development from latent to declared disease, should be adequately understood. There should be an agreed policy on whom to treat as patients. Cost, again, plays a major role. And case finding should be a continuous process. So this technique everybody is aware of, dried blood spot technique. It's quite simple. So how is this test done? First of all, the samples ideally should be obtained as close to hospital discharge as possible. Why this time interval? Because we all know that before the baby is born, the placenta will filter out or excrete all the abnormal metabolites. And if we take the sample as close to hospital discharge as possible, that much time is available for the abnormal metabolites to build up, especially after the baby has been started on feeds. The samples are generally obtained by puncture of newborn's warm heel, and they are collected on a filter paper, which I showed in the previous slide. Appropriate documentation, including patient's name, birth date, and time, is very important. We must remember that these are screening tests that we are recommended for. So any child who turns out to have a positive screening test, you must follow up the child and ensure that a diagnostic test is done as soon as possible. Now, newborn screening tests, which are these tests that we do by using the dried blood spot, there can be several false negatives also, which we should be aware of. Specifically in preterm babies, if the child has received a blood transfusion, any dialysis therapy, or those who were tested too early, we should be careful before interpreting these results. There can be false negative in these patients. Collaboration among healthcare professions is extremely important. I would like to emphasize the importance of antenatal counseling and the role of the obstetrician here. These patients are following up with the obstetrician throughout their pregnancy. They have immense faith in the obstetrician. Suddenly, when a neonatologist or a pediatrician they meet after the delivery is an alien person to them. Newborn screening, because of the cost involved, very often it can be misunderstood as being a money-making business. So if these parents are counseled before the delivery, convincing them by the pediatrician and neonatologist would be easier. Pediatric medical subspecialties play an important role when a child is diagnosed to have a specific condition, where they will be involved in the management as well. So we are basically looking at newborn screening program in India. Is it a hype or a hope now? Should we be looking at newborn screening? How important is it in the Indian scenario? We have a lot of issues to deal with in India already. So are we justified, and what is the evidence that we are recommending newborn screening program? Because of course there is a lot of cost involved in it. So according to the WHO recommendations, genetic services should definitely be offered in conditions which have an infant mortality rate of less than 50. IAP strongly advocates inclusion of newborn screening in the public health policy. We all know that the incidence of metabolic diseases in India is very high because of our high annual birth rate. The numbers and the figures of these babies that we look at are very high. Like you can see, because of our high annual birth rate, the incidence is very high in India. So we certainly have to think about recommending newborn screening. Now there was an article, newborn screening is very confusing. So a lot of people might recommend these are the conditions that the baby should be screened for. Another person might say 5 conditions, somebody else might say 40, 50 disorders. So how do we simplify things? Again, there was an article which was published recently in Indian Pediatrics, which made things simpler for us and helped us to classify these conditions. Whenever we talk about conditions or diseases for newborn screening, there is a core panel and then there is an expanded panel. So what do these two conditions mean? Whenever we talk about core panel, these are the basic minimum set of disorders for which screening should be advocated at a national level. So basically, we are recommending these for all babies. Then we have an expanded newborn screen, which has emerged after the introduction of TMS. With the availability of this, we can do mass screening for a number of disorders. So when we decide a core panel, the core panel in different countries is different, which is basically formed depending upon the incidence of the disease in that country, what is the epidemiology, what is the cost involved, and it is different for different countries. So in India, what should be our core panel? I would like to present some evidence for it. Now category A, in this article what they have done is they have classified these diseases into category A, B and C. Now category A is basically the conditions for which, as based upon evidence of cost and studies which have been published, every newborn should undergo screening for these basic minimum set of conditions. So what are their recommendations for the Indian scenario? First of all, congenital hypothyroidism, which I'm assuming that is being done in most of the centers and most people are screening for congenital hypothyroidism. Second is CH, G6PD, galactosemia should be added. G6PD screening absolutely essential in the northern states of the country because of the high incidence. And sickle cell disease and other hemoglobinopathies can be undertaken in pockets of high incidence. So basically, we are recommending that all newborns should be definitely screened for hypothyroidism, CH, G6PD, galactosemia. Why? I'll be talking about it in the next few slides. Now category B, these are the screening for high-risk babies. So basically, these patients who fall into the high-risk category should be offered the expanded screening. What is the high-risk category? You ask for a history of consanguinity, any previous children with unexplained intellectual disability, seizure disorder, previous unexplained sibling death, critically ill neonates, newborns or children with signs and symptoms which are suggestive of an inborn error of metabolism. So you must recommend the expanded screening in these patients. The third category is the category of in a resource-rich setting, where money is not an issue. So you can counsel the parents, and this can be offered to parents where cost does not play a factor. You can offer an expanded screening for 30 to 40 inherited metabolic disorders. Now we all recognize this baby. This baby is a case of congenital hypothyroidism. This child came at 3 months with poor growth, delayed developmental and mental retardation. Now what comes to our mind is, are we late? Could we have prevented this from happening, and is it a treatable cause? Of course, the answers to all three are yes. Now what is the rationale for screening for congenital hypothyroidism? Now if you screen the child if the child is screened beyond 3 months of age, the IQ is less than 90. If you screen this child within the first 6 weeks of life, the IQ is more than 100. And all those patients who are diagnosed on neonatal screening program and treated immediately have a normal IQ. So here we can see by a simple newborn screening test, we can improve the long-term outcome of this child. Now, congenital hypothyroidism, 85% of the permanent cases are sporadic. So you might not have a risk factor, you might not have a history. Now, most of these cases are caused by thyroid dysgenesis. Sometimes it can be a transient cause. However, even patients who have transient hypothyroidism, these children definitely need to be treated at least up to 3 years of age. Now, what are the cases of transient hypothyroidism? They can have transient hypothyroidism because of the mother is on antithyroid drugs, maternal blocking antibodies, exposure to iodine or iodine deficiency. We all know that maternal hormone crosses the placenta. So even children who actually have congenital hypothyroidism might have some residual thyroid function present, because of which more than 95% of them are asymptomatic at birth. So in these children, you might not get any symptoms. There is no history present. These are sporadic cases, or it can be transitional. So the only answer is, the only way you can pick up these babies is by screening them at birth. Now, congenital hypothyroidism, as far as the incidence is concerned, it is very high. You can see the numbers in different parts of the country. We have a significant burden of congenital hypothyroidism in India. And most importantly, it is a preventable cause of intellectual disability. Now, how do we do neonatal thyroid screening? First of all, either a cord blood sample is taken or a sample can be taken after 72 hours. The cutoff values for cord blood most commonly use are 20. Different studies quote different levels. However, universally we are using cutoff as 20. What are the tests which we can do? Either TSH alone can be done, or T4 and TSH is a better way of doing thyroid screening. However, TSH alone is more cost effective. So most people are doing cord blood TSH. Now, whenever you are doing cord TSH, you have to be aware of the limitations of this test. First of all, you can get falsely high values initially, and overdiagnosis is possible of congenital hypothyroidism, especially in preterm babies. These babies might have initial high levels of TSH. Why? Because they have low iodine stores which are achieved in utero, and there is an immaturity of the hypothalamic pituitary axis. So we are discussing the limitations of cord TSH screening. Secondly, we all know that there is a TSH surge which takes place at birth. So immediately after birth, the values of TSH are high. After 24 hours, they drop to 20, and by 1 week, the values should be about 6 to 10. So TSH of more than 10 after 1 week should be considered as significant. So the two tests available, what we said, were initial TSH, or you can do an initial T4. When you do an initial TSH, it can detect subclinical hypothyroidism, because patients of subclinical hypothyroidism will have normal T4, but they will have a high TSH. However, you can miss central hypothyroidism. Initial T4 assay can miss subclinical hypothyroidism. So whenever we recommend newborn screening for a particular condition, you have to be aware of the limitations and the age-wise cutoffs of these values. Any child with an abnormal screen should be recalled for testing. And in this time, when we recall the child for testing, you should be taking a venipuncture sample. And age-specific norms should be used as the cutoff values, because we all know that values can be higher in the transiently high in the first few weeks of life. The second condition that I hope after this everyone is convinced that hypothyroidism screening at least should be done. Now the next condition I'm going to talk about is classical CH. So I'm talking about the basic 4 minimum conditions that I strongly feel and evidence strongly supports screening. The second condition is classical CH. Classical CH can present in 2 forms. One is a salt losing form and the second is a virilizing form. Now patients with classical 21 hydroxylase deficiency also are known to have mineralocorticoid deficiency. So this places them at a very high risk for volume depletion, hyponatremia and hyperkalemia. So these children can present to you in shock with volume depletion, with electrolyte imbalances, and they present an adrenal crisis. It is one of the more common inherited disorders according to all the studies which have been done. Now girls can very often with CH are picked up because they can have ambiguous genitalia, though that may not be present always. However, chances of picking up a girl with CH will be higher. Now affected females, if they are missed and they don't have ambiguous genitalia, these children can also present with a salt losing adrenal crisis at 1 to 2 weeks of age. And newborn males very often will not show any overt signs of CH, although phallic enlargement and scrotal hyperpigmentation can sometimes be present. Boys will present with salt losing adrenal crisis, with hyponatremia, hyperkalemia and failure to thrive. With neonatal screening programs available, affected males can be diagnosed before they develop these clinical symptoms. That is our aim with newborn screening. Now CH, as far as data in India is concerned, of course, whenever we are recommending screening for a particular condition, our data should be in place and it should be significant. So data from eastern part of the country by Methi and Chatterjee shows that mean age at diagnosis in the salt wasting group was 0.5 years, as late as 0.5 years, and simple virilizing group was 9 years. Majority of these patients who were picked up were girls. Now skewed male to female ratio suggests that substantial portion of the males were being missed. Why they were being missed, we have already discussed. Now because this could be that these males were either dying early or there is non-recognition of the disease in males. In countries where routine neonatal screening is not available, the diagnosis is made as late as after infancy at times. Test that is available for classical CH is 17-hydroxyprogesterone. Again, filter paper blood sample is obtained by heel puncture, and preferably these tests are done between 2 and 4 days after birth. Most of the affected neonates will have concentrations above 3,500. That is the cutoff that is generally taken. However, we must remember that though false positive results can be there with premature and sick infants, and false negative. Now you should be careful about the false negatives. So false negatives can take place in girls and if antenatal corticosteroids have been used. So if there is a negative newborn screen, but on clinical grounds you are suspecting CH, these children should be tested at a later date. So any newborn screening is of course not foolproof. You should know the false positives and the false negatives. Treatment we all know is easily available. Glucocorticoids with or without mineralocorticoid therapy is the treatment for CH patients. And if undetected at birth, it can result in morbidity, mortality or genital abnormalities. Surgical intervention like clitoral resection is also available. So here we have a test which we know can be missed initially. If newborn screening is not done, treatment is easily available and confirmatory tests are available. Plus data strongly supports screening CH again. Third condition that I would like to talk about is G6PD. Now you can look at the data. We are looking at a burden which is nearly we can look at the huge burden of the condition in our country. Northern India incidence is 1 in 1200, Eastern India incidence is 1 in 15. It is an X-linked disorder. It is the most common enzymatic disorder of red blood cells in humans. Affected patients again are usually asymptomatic at birth, so you might not pick them up. All we have to do, these patients require, is avoidance of certain drugs and foodstuffs which can initiate hemolysis. So here we have a condition again where you can do a simple screening test and you can counsel the parents that this child you need to avoid certain drugs and foodstuffs, and you can prevent the child from landing up in trouble with hemolysis. So patients with G6PD very often come to us with episodic anemia, chronic hemolysis and sometimes severe hemolysis, and with anemia, hyperbilirubinemia induced by exposure to drugs which have a high redox potential. So you can counsel the parents to avoid antimalarial drugs, certain sulfa drugs, favipiravir, selected infections and metabolic abnormalities. Now G6PD screening, there are a number of screening tests which are easily available for diagnosing G6PD. Confirmatory tests are also available. False negative tests, you should be aware that false negative can happen if the child has an episode of hemolysis at that time. So if there is an acute hemolysis going on, you must repeat the test at a later date. Subjects with G6PD should avoid drugs and chemicals with oxidant potential. The fourth condition, so we have spoken about 3 conditions now. One is congenital hypothyroidism, CH and G6PD. The fourth condition that we strongly recommend newborn screening for is galactosemia. Now galactosemia can result from deficiency of different enzymes. We have learnt about this in our undergraduate days. Now this is galactose 1-phosphate uridyl transferase, galactokinase deficiency and epimerase. Infants with classical galactosemia usually present in the first few days after birth, after initiation of breast milk or cow milk based formulas. What is the presentation? They will present once they have been started on feeds with jaundice, vomiting, hepatomegaly, failure to thrive, poor feeding, lethargy, diarrhea and sepsis. Very often these children are very bad, and all we could have prevented it by recommending screening at birth. Early diagnosis and treatment, like we saw, can prevent life-threatening complications. Without early treatment, sepsis due to E. coli can be fatal in the neonatal period. Lactose-restricted diet, which is provided in the first 10 days, can actually reverse the symptoms of galactosemia. We have both screening tests and diagnostic tests which are available. Fluorometric assay of GALT enzyme activity can be done, and quantitative assay of red blood cell GALT activity is necessary to confirm the diagnosis of classical galactosemia. So again, we have a screening test available, we have a diagnostic test available, something preventable. If the child was screened, we could have prevented complications. Now here is an important case. A 12-month-old child presents with delay in speech and language. The first thing when a child comes to us with delay in language, the first thing we ask the parents is, can the child hear? So next thing I'm coming to is hearing screening for every newborn. Now what is universal newborn hearing screening? We all know that the incidence of hearing loss is pretty high, 2 to 4 per 1,000 live births. Now prevalence is twice that of other newborn disorders which are amenable to screening. 50% of these cases are genetic. So we don't have any identifiable risk factors by which these children can be picked up. Early detection and intervention is always our aim. Early intervention can improve speech and language development in these children. Very often caregivers and clinicians will detect hearing loss when there is already a delay in speech and language. So when the child comes to you with delay in speech and language, that is when these children are sent for hearing screening. Infants with hearing loss are more likely to be detected at an earlier age and receive early intervention with the advent of universal newborn hearing screening. So if you do a universal newborn hearing screening, there is a better chance that these children will be picked up early before there is delay in speech and language. As far as the Indian experience is concerned, there are several studies which are published. I'm just quoting 2 of them. More recently is the Indian pediatric study, which was published in 2014, where they screened 9,448 babies over 11 months, and 39 patients were confirmed to have hearing loss. Now tests which are available, there are 2 tests which are easily available for hearing screening. These are simple tests. One is OE and ABR. OEE is a cheap, quick, simple and reliable test, not very costly. Advantages, it can be administered bedside even when the child is awake. The only limitation of OEE is that it will not pick up auditory neuropathy. However, in the well baby nursery, where we are recommending OEE screening, anyways the incidence of auditory neuropathy is not very high. Now what is OE? I'd like to show you. So this is the equipment. This is what is called as the Auto-Red. It is a very simple equipment. You can see in the picture how the test is performed. There are probes which are available, which should be fitted properly. It is a bedside. It can be done bedside. It does not require much training. Very simple test. So what does it do? It assesses the structural integrity and response of the outer hair cells of the cochlea to acoustic stimuli. So any acoustic stimuli that is delivered by this equipment, it is the response of the outer hair cells of the cochlea will be picked up. Sensitivity and specificity both are good. Ideally, it should be done at 34 weeks of corrected gestational age. You can do it earlier in premature babies, but it might not be that reliable. Ideally, it should be done beyond 34 weeks. However, limitations of this test are that effectiveness can be decreased if there is a lot of noise in the NICU at that time or in the well baby nursery, if there is any middle ear pathology or any debris. Now second test that we come to is ABR. What is ABR? It basically identifies auditory neuropathy which cannot be picked up by OAE. Sensitivity of this test again is good, 99.9, and specificity of 97.9. However, we must remember that OE and ABR are both screening tests and they do not give us frequency specific information. So children who have failed these tests should be rescreened at least by 1 month of age, and if they fail both the tests, then a diagnostic audiologic evaluation should be done. Here with these tests, you will just be able to screen whether the hearing is normal or abnormal. The results are generally pass or fail. And in children who have failed both the screening tests, you need to confirm it by detailed audiological diagnostic evaluation. Again, ABR you should do preferably best done at 34 weeks of corrected gestational age. Now AAP way back in 1999 has advocated universal newborn hearing screening program, which is being followed in most of the developed countries. However, unfortunately in India, despite of us having so many NICUs in the country, adequate screening facility is lacking. So I think the issue is about awareness and probably commitment motivation. So how should we be following universal newborn screening? Should we just be screening babies who have risk factors, or should it be a universal program? So what are the risk factors for neonatal sensory hearing loss? First of all, if there is a family history of permanent hearing loss. Secondly, children who have craniofacial abnormalities involving the external ear, congenital infections such as meningitis, CMV, toxoplasma, rubella, herpes, syphilis, any physical findings which are consisting with an underlying syndrome, NICU stay of more than 2 days, or any of the following regardless of the duration of stay. If the child has received ECMO, assisted ventilation, any ototoxic drugs that were used, hyperbilirubinemia requiring exchange transfusion. However, we need to be aware that these risk factors might be present only in 50% of the children with hearing loss. Remaining 50, you might not have any risk factors. So, universal versus a risk-based approach. Ideally, every child should be screened for hearing. Because if we follow a risk-based approach and screen only those children who have risk factors, a high percentage, almost 42% of profoundly hearing impaired babies can be missed. Secondly, age, the identification and intervention before 6 months of age has proven to have improved language and speech development. So, strongly recommend universal newborn hearing screening. How is the screening done? Either it can be a single stage or it can be a 2-stage process. What does a single stage process mean? That one test is used, either OE or ABR, and it is a single test is performed. So what are the disadvantages of this? Although it can detect almost 80 to 85% of the cases, however, very often you can get high false positives, and there can be a high referral rates if you screen the child only if you follow a one-step program, that is only one test is performed once. Secondly, it increases, because there are high false positives and high referral rates, it will increase the overall cost of universal newborn hearing screening. So ideally, we should be doing a 2-step program. That is, if the child faces the first newborn hearing screening, the second test should be offered, and patients who fail both, you refer for an audiological assessment. This, if we do a 2-step program, then there is decreased chances of having false positives and decreased referral rates. Of course, the cost goes down. Limitations, false positive, like we saw, 30% with a 1-step program. If we follow a 2-step program, false positives are reduced to 1%. Now, parental anxiety is an important issue, because at birth, if you tell the child that a hearing screening has been done and your child has not passed the screening, there can be a lot of parental anxiety. However, you need to reassure them that this is a screening test, there can be false positives, and we need to screen your child at the next visit. So what are the recommendations? Initial screen, OE, ABR, or both. 2-step screening program is strongly recommended. If you are using a 1-step program, ABR is a better choice, because low false positive rates with that. Re-screening, if the child fails the first test, should be done before 1 month of age. If the child does not pass a re-screening, diagnostic audiological evaluation should be done for this child. When you have NICU, so in the well baby nursery, you can recommend OE or ABR. However, in the NICU graduates, OE is not good enough. Every NICU graduate should have an ABR done. Secondly, you must remember that those patients who have risk factors, we saw the long list of risk factors, all these children might have a normal newborn hearing screening at birth, but with risk factors, you need to follow them up every 6 monthly until 3 years, because very often sensory neural hearing loss can be a progressive condition. So even if the initial screening is negative, these children later on are at risk. So you should follow them up every 6 months till 3 years of age. So what are the essential messages, key messages that I want to give? Now, essential newborn screening, we'll divide it into 2 parts. First of all, blood components. So congenital hypothyroidism, CH, G6PD, galactosemia should be done for all newborns. As far as the clinical screen is concerned, so these are only the blood components we are talking about. The clinical screen is as important. Every child should have a pulse oximetry screening, a pre-discharge bilirubin screening, universal newborn hearing screening, red reflex and DDH. Clinical screen and pulse oximetry will be covered in the next few lectures. So I feel every newborn definitely deserves screening. Thank you.